رائد العوايشة، دكتور إبراهيم جراد، هاني عبد الهادي، دكتور نزار الشخشير، دكتور حسام مساد. لا هذا السيشن بدنا فيه زيادة. دكتور عدنان بتحب دكتور رائد. It's not enough.
I will present the Klaus Bonaventura first. Yeah. Most welcome. I really appreciate everyone still sitting here for the end of the day. Really, I appreciate that, and I feel proud actually to have all of these number waiting, and really it is enjoyable. Otherwise, most of the people will not see here. Thank you very much for staying with us. So for no further delay, we will present the one who delayed. Most welcome. I'm really glad to present Dr. Klaus Bonaventura to present drug-coated balloons in De-Novo lesions. Actually, we have a long discussion about the DCB before you come, and we are waiting for answers for questions you don't know. So be ready.
Thank you.
Thank you.
And I'm really sorry for the delay. I missed my connection flight yesterday. There's always once in a lifetime, and yesterday was the first time. So thanks for the organizers, thanks for you all for staying here and for giving me the opportunity to have this talk now about the drug-coated balloon in De-Novo coronary lesions. This is my disclosure. We all know how the DCB works, but nevertheless, I love this picture a lot because it totally explains how the DCB works. It's not, to be honest, it's not that complex. It's just leaving the lesion site with the drug to prevent neointimal proliferation. But even if we have a huge market, an upcoming market of DCB, there is no class effect because the matrix coating, the coating decides how much of the drug is available once we have reached the lesion site. And again, there's no class effect in DS and there's no class effect in DCB. When we're talking about drug-coated balloon, there are always two major concerns. The one is, what is the efficacy of the use of a DCB in De-Novo lesions? And the second is, how can I leave a lesion without a stent? What about safety? This lady presented for elective intervention of the obtuse marginal branch. She had a positive stress test for the lateral wall, and what you see on the left side is a moderate lesion of the ostium of the obtuse marginal branch. We did lesion preparation with an emerge 2.515, and if we treat this lesion with a DCB, we all know the DCB should extend the previously treated lesion by 2 to 3 millimeters on both sides. So by using a 15 millimeter balloon for lesion preparation, we're using a 2.520 secant please neo for the lesion, so covering around about 3 to 5 millimeter in the main branch. And you see on the right side the final result after the DCB. You might agree it's an acceptable result, but the lady came back after 4 months, and now you see the positive remodeling and the lumen enlargement, which happened after 3 to 4 months routinely. Again, on the left side, the result at the index procedure with a residual lesion of maybe 30–40%, maybe type C dissection, and a brilliant long-term result after 4 months. This positive vessel remodeling, this lumen enlargement, is not a single case. I mean, all of you which routinely use the DCB know this phenomenon. We see this lumen enlargement in about 60% of the cases. We used to see this, but what is, in my opinion, at least that important is the fact that we keep the vasomotion. This study included 132 procedures. They're all done with the DCB secant please neo, and they checked the response to ergonovine and to the nitrates at the 6 to 9 months angiographic follow-up. And they compared the previously treated segments with the DCB to never treated segments, so to normal reference segments. And they checked how was the response to vasoconstriction and to vasodilatation. And the DCB treated lesions first showed no particular vulnerability to vasospasm. There was not an increased reaction to vasoconstriction. But what is, in my opinion, tremendously important is that they showed a similar vasomotor function to angiographically normal segments. So what we tried to get by using the BVS, we get by using the DCB. This lady presented with a positive stress test for the anterior wall. It's a 50-year-old lady, and you see in the aerial view it's a moderate lesion of the ostium of the LAD. In the lateral view, you might agree it's an eccentric significant lesion. We predilated this with a 3.015, in my opinion, a little bit undersized when we look back. We treated this with 3.515 and found that the immediate result after lesion preparation was acceptable. We treated this with a sigmoid neo, it's 3.020. In this situation, we keep in our mind that inflation time is recommended with 30 to 60 seconds, but we have preclinical data showing that even 10 seconds are enough. And in a situation like this, when you count the seconds, even 10 seconds are fine. So this was the result after DCB, and you might all agree this is not a DES-like result. It's a DCB-like result with a resolution of maybe 40%. We left it like this, and again in the area view, this was the result of the index procedure. The lady came back after 4 months, and we see a beautiful long-term result after the 4 months. And this again is the cranial lateral view, still showing a beautiful long-term result, and by chance the lady came back after 4.5 years, and we still see this beautiful long-term result at the ostium of the LAD. In the meantime, we have hundreds of data, hundreds of randomized controlled trials with thousands of patients in RCTs showing efficacy and safety in small vessel disease and in large vessel disease. The basket small 2 trial included 883 patients with De-Novo lesions in a diameter from 2 to 3 millimeters or 2.75 millimeters, all treated or with the circumflex neo or with a DES, and they started with the taxus and they ended with the science. And primary endpoint was the clinical outcome at 12 months, including cardiac death, non-fatal MI, and target vessel revascularization. And DCB was non-inferior to the use of a DES, and the result in MACE was exactly similar between science and circumflex neo. So it was called basket small 2 trial, but in fact the mean size of the DCB was 2.75. So we have not only results for small vessel disease, but also for larger vessels. But we have even more data, such as the DEPO trial or the results from this Chinese institute. They included almost 600 De-Novo lesions, 222 in large vessel disease, 373 in small vessel disease. And they checked the clinical follow-up after 10 months, and you see MACE 1.4 in the small vessel disease group, TLR was 1.1, but there was 0 in the large vessel disease group. So what works in small vessels definitely works also in large vessels. And the group also did the angiographic follow-up in 91 lesions after a time horizon of almost 11 months. And you see late lumen loss in the total cohort was minus 17 millimeters. And it was minus 17 in the large vessels as it was minus 17 in the small vessels. So we see the similar effect of a positive remodeling in small vessels and in larger vessels. This is the recommended treatment algorithm for the use of DCB in De-Novo coronary artery disease. We start with the lesion preparation, and after the lesion preparation, we check the immediate angiographic result. And if the angiographic result is acceptable, we use the DCB. If it's not acceptable because we have a reduced TIMI flow, a residual lesion of more than 30–40%, then we're using a DES. There are 2 crucial points in this algorithm: the lesion preparation and the dissection. First, we don't call it lesion preparation, and we had the discussion in the session before. Lesion preparation is a crucial point. It's a challenging point. So now at times we have so many tools in our CAS lab. Not only the balloon, we have rod ablation, we have the intracoronary lithotripsy, we have tools to measure the result of our lesion preparation with the FFR measurement, we have intravascular imaging techniques, and we should use all these armamentarium, all these tools not to do a lesion preparation. We should achieve the best possible and optimal lesion preparation. We did a study using the scoring balloon, the NSA alpha, to use a routine lesion preparation or plaque modification prior to the use of a DCB of the secant neo. We included almost 500 lesions. It was a multi-center, single-armed, all-comer study in patients with a focus on De-Novo lesions, and the clinical outcome in those patients who were treated with De-Novo lesions after 9 months was TLR of only 0.8, target lesion failure 1.1, and not any event of thrombosis or myocardial infarction. And by the way, there was no difference whether the vessel was calcified or not, and there was no difference whether it was a small vessel disease or it was a large vessel disease. Lesion preparation is a key step. It's a very important step for any procedure and for the DCB procedure. Second, what about the dissections? I said, okay, if the dissection is relevant, we use the DES. If it's not relevant, if it's A-B dissection, we use the DCB. This study included 227 patients, and they checked the relation between a non-flow limiting coronary dissection and the clinical follow-up. All patients were treated with a lesion preparation followed by DCB secant please. And you see in the angiographic follow-up how the dissection disappears with time. And they included all patients with non-flow limiting A, B, and C dissections. And you see after the follow-up of 6 months, there was no dissection anymore. Only 0.5% of patients with a type A dissection. All the others, whether it was A, B, or non-flow limiting C dissections, disappeared. And there was no clinical impact of this dissection or no dissection. There was no difference in the clinical endpoint. So what dissection is uncomplicated in 2023? It's different than the former classification from 1985. What dissection is uncomplicated in the era of routine and effective inhibition of platelet aggregation? It's type A dissection, type B dissection, and no flow limiting type C dissections. But nevertheless, we have still concerns in safety. What is the risk of thrombotic events? We had to learn that the risk of thrombotic events in treatment of De-Novo coronary lesions is lower after the use of the DCB than after the use of a DS. In the Basket Small 2 trial, it was exactly 0%. And it is recommended to treat our DCB patients with 4 weeks of DAPT in stable coronary disease and 6 or 12 months in patients with acute coronary syndromes. What about the future, or is there a future for the sirolimus-coated balloons? I mean, we all know sirolimus is definitely better than the paclitaxel cell on the stent, but can we transfer this experience also on the DCB? They work completely different. Mode of action is different. Tissue absorption with the sirolimus is slow. It's fast with the paclitaxel cell. I said 10 seconds are fine. Tissue retention is different. It's short with the sirolimus and it's long with the paclitaxel cell. This works. The sirolimus works well on the stent, but the question is, will it work on the DCB as well? So we have first studies such as this one, including 101 patients with DES instant with stenosis, and they compared the paclitaxel-coated secant please neo with the sirolimus-coated secant please neo, and primary endpoint was angiographic late lumen loss at 6 months, and there was no significant difference. Not better, not worse. In this total field of sirolimus-coated balloon, there are a lot of studies ongoing and planned in the future, but so far we have very limited published clinical data, not showing so far significant advantages for the sirolimus. It's a pleasure to meet you here, and we share the same problems, whether we treat our patients in the cath lab in Germany, in Europe, or in your region. It's our job to treat coronary lesions and prevent restenosis. And by doing so, we have 2 major tools in the cath lab. The DS, the new generation DS, and the DCB. And the key question is, when to use what? Yes. And each of the single approaches has its own strengths and the weaknesses. And the so-called hybrid approach combines the strengths of both. we call it the hybrid approach of PCI. We learned that drug-coated balloons have lower or comparable TLR compared to new generation DS. They keep the vasomotion in contrast to the DS, and they need shorter duration of the APT compared to new generation DS. On the other side, new generation DS are superior to DCB to treat severe recoil and flow-limiting dissection, but they have a persistent risk of late or very late stent thrombosis. What to do decides the result of the lesion preparation. This study checked exactly from Shin, from Korea, checked exactly this strategy and compared the hybrid approach with the standard DES approach. So they included 254 patients with multivessel disease treated with DCBs or in combination with the DS, compared to a matched group treated only with the DS. And you see the clinical outcome at the 2-year follow-up was significantly better by using this open strategy and to decide step by step and stenosis per stenosis, what is better, the DCB or the DS? It's definitely better, and we see the clinical outcome significantly reduced with this hybrid approach compared to the DS-only approach. My last 3 cases. This female lady presented with 63 years and STEMI case with an intervention of LAD diagonal branch. The RCA was not significant lesions, but we see this Medina 111 situation in the mid-LAD. We did lesion preparation with Emerge 3.5 and Emerge 2.75, and on the right side you see a not acceptable result with this flow-limiting dissection in the diagonal branch and a residual lesion more than 50% for the LAD. So we decided to use 2 DES Corflix ISA Neo. We used it simultaneously and did a post-dilatation and a pot and a kissing, final kissing, and the final result after 2 DES Corflix ISA Neo in LAD and diagonal branch was acceptable, and the lady came back after 3 months with this technique, and we still see a beautiful result. But the result of the lesion preparation was not acceptable. Almost the same situation, this older lady, 84 years old, presented also with unstable angina, and again, LAD 111 situation, and we pre-dilated, in this case with 2 scoring balloons. It's a NSA alpha for the mid-LAD 3.513 and an NSA alpha 2.513 for the diagonal branch. In this case, the lesion preparation was acceptable for both. We see an acceptable result for the diagonal branch and an acceptable result for the mid-LAD. So we decided to use 2 DCB, and we started with the Signal Neo 2.520 for the diagonal branch, followed by 3.520 for the mid-LAD. And also the final result was very acceptable. So we left it like this, and the lady came back after 3 months for a procedure of the circumflex, and we see a beautiful result with 2 DCB in this complex lesions. FFR of the mid-LAD was negative, by the way. And finally, the last case, 55-year-old lady, stable angina, positive stress test for the lateral wall, and we see 3 tight lesions in the proximal and mid and distal circumflex. We did lesion preparation with 3.515 for proximal circumflex, 2.515 for mid and for the distal part, and you see a not acceptable result for the proximal part, but an acceptable result for the lesion preparation for the mid and for the distal part. So we decided to use the DCB for the mid part and for the distal part, using 2 2.520 Signal Neo, and the Corflix ISA Neo for the proximal part, it's 3.516. And this is the result after 1 stent and 2 DCB, very acceptable, and the lady came back after 4 months, and we still see this beautiful result for the stent, but also for the 2 DCB. This hybrid approach of stent and DCB means to consider all options. A stent-only approach, a DCB-only approach, or a stent and a DCB, sometimes in one vessel, but sometimes also in one lesion. We call it the individual interventional therapy. Ladies and gentlemen, DCB showed proven efficacy and safety in de-novo coronary lesions, so therefore DCB needs to replace the stenting if stenting is only for the application of the drug to prevent restenosis. Optimal lesion preparation is a key step for the treatment algorithm, and the hybrid approach of DCB and stenting uses all contemporary tools to achieve the best interventional and clinical result. Thanks for your attention.
Thank you. Would you like to take this discussion now, or just for the DCB, because it is different, the subject will be different now? Okay. So I thank you for the short of time. Maybe we have many questions for you. We retrieve them from the previous session. So next speaker will be presented by
Haitham Sholy. So what to do when things go wrong in left main PCI? Dr. Haitham Sholy.
Good evening, everybody. I just would like the committee for giving me the opportunity to share my case. I'm going to talk about a left main stenting case. A 60 years old gentleman with a past medical history of diabetes mellitus, of peripheral arterial disease, renal replacement therapy 4 times per week, and hypertension uncontrolled, COPD, non-CAD with non-STEMI and PCI to osteal RCA in 2022, and who was admitted to our department with non-ST elevation KLIP2. His blood pressure is high, and here's the heart rate. His ECG showed a sinus rhythm with ST segment elevation, AVR, diffuse ST segment depression, and echocardiography showed mildly reduced LV systolic function with EF about 50%. And we decided to proceed to coronary angiography. And as you can see here, the previous stent in the RCA is protruded to the aorta, maybe 5 millimeters. Whoa. And in non-selective injection, you can see that there is no ISR. And fed to the ECG findings and the echo findings, you can see here this a severe lesion, severe stenosis in the ostial left main, and it seems to be calcified. The operator at that time decided to proceed to PCI for ostial left main, and as you can see here, after balloon dilatation, he implanted a stent in the ostial left main in caudal view. As you can see here, the stent is protruding to the aorta, and here's the implantation. So it was severely protruded to the aorta, and then after injection, he thought there is something wrong with the distal part of the stent in the left main, and you couldn't recognize at that time that the stent is protruding, almost all the stent is protruding to the aorta, and decided to implant another stent distal to this stent. As you can see here, this is the first stent result, and this is the second stent overlapping with the first stent, the distal part of the first stent, maybe 3 millimeters, and this was the final result. A bad result, it's still be stenotic, the ostial left main still be stenotic, and almost about 10 millimeter stent is in the protruding to the aorta. This is, then they transfer the patient to the ICCU and perform TE, transesophageal echo, and in transesophageal echo you can see the stent. You can see the stent protruding to the aorta. We measure 9 to 10 millimeter stent in the aorta, and a high velocity in the ostial LED, indicating a severe stenosis still being there. What will you do at this level?
Kill the operator.
Maybe microphone.
من البداية كان لازم نسوي سنيرنج للستنت الأول.
But you have the patient with
okay,
two
the
stents
situation
now.
is right now.
You can snare the distance. The first stent, not the second.
So, reviewing the literature about protruding stent from coronary artery to the aorta, Protrusion can happen immediately, as in our case, and after intervention due to migration of a stent, like in Kawasaki patients where the aneurysm that continue to dilate and the stent can move proximally. And complication of excessive stent protrusion include stent fracture, difficult re-intervention due to difficult engagement, absence of endothelialization of the stent, and then stent thrombosis, and interfering with the aortic valve and coronary cusp perforation, severe aortic insufficiency, and maybe pulmonary edema. When reviewing the literature, some decided to follow up their cases. Some sent the patient to surgery in order to take the stent out, to remove the stent. And a few cases was described that they deal with the stent in the cath lab. All the cases that I found in the literature is not identical to our case. And I found this paper in the Catheterization Cardiovascular Intervention Journal in 2020 in August, a case of 4 cases series and a review of the literature. The first case was RCA. In the index procedure, the stent was protruded and they simply snare it only without any safety consideration. At the second case, there was a patient after CABG and SVG, occluded SVG to left circumflex, and they decided to stent from left main to circumflex. Then they lost the wire, and rewiring between the stent and the vessel wall in order to make a pot, proximal optimization, and the balloon of pot was inflated, crushing the stent, and actually they retrieve not fully deployed stent, but a crushed stent. So it's not similar to our case. And the third and fourth case are a case of SVG and RCA that was implanted protruding to the aorta, and simply they snare it only without any safety consideration. Most reports of stent retrieval involved undeployed or embolized stents, while the retrieval of fully deployed stents has been sporadically reported, as in the case reports here. More of them was not intentional. The feasibility and safety of intentional retrieval of fully deployed stent have not been well described. They reported 4 cases, as you could see, and from these 4 cases, they concluded that intentional retrieval of fully deployed stents is feasible and safe when stenting involved and an aortoosteal location. Back to our patient, why to remove the stent? The lesion is still stenotic, highly velocity, and geographic appearance is bad. The patient is still symptomatic. We decided to remove it 4 days after the implantation because the team that was at that time is not a complete team. The patient have uncontrolled hypertension, and considering giving him a long-term DAPT, it's a problem. The patient on IV nitroprusside and oral medication keep being on high blood pressure, just 190 millimeter mercury systolic blood pressure. This patient have a clotting events of the extracorporeal circuit during dialysis. The hemodynamic during renal replacement therapy during dialysis is bad, and it's a prothrombotic environment. It will be difficult to re-intervene if needed, and if needed, it will be stent thrombosis. It will be more difficult than we imagine. And I said one day before performing the procedure, try to planning something in order to be more safe. And I decided to take one catheter from one axis with the snare, and then insert this is the line between the aorta and the left main, in order to insert the stent in the snare loop from this catheter without closing the snare loop. Then taking another catheter from another axis, going with a wire from the protruding stent struts into the left main, and putting a stent there, just parking in case of dissection while removing the stent. And another wire in the stent, in the part of the stent that protruding to the aorta from the same catheter, from this catheter. And why we need this wire? I took 2 stents with me home. One stent I took a wire in it here and inflate a balloon. And as you can see here, forming 2 bands, like 2 bands. And when we pull the stent out, all the forces will be applied here and not distributed for all the bands. And the stent that we form these bands in it, this stent, when we try to pull it, fixing the distal tip and pull it, it elongates much less than a stent that we didn't perform this maneuver on it. So we need to access the left femoral axis was not, there was an occlusion in the left iliac. So we went, our axis was the right femoral approach. And this, as you can see here, the first step was inserting the protruding part into the snare. Second catheter, as you can see here, wiring from the protruding segment in the aorta, coming with a balloon in order to make a small inflation in order to put a stent there, parking there for safety. When I came with the stent couldn't pass even if we have a small dilatation there. So I decided to go to park with a balloon for safety. This balloon is 4.6 millimeter. And the last one was the wire going in the protruding part in the aorta and then inflating balloon there in order to form the 2 bands. And now when we close the snare, there are 2 scenarios. One scenario that we could retrieve, that we will retrieve all the stent, all the parts of the stent, even the overlapped with the distal stent. And in this case, all the instrument that we have there from the left radial approach in this case will be like one unit with because all the instruments are crossing the protruding part in the aorta, and if we take all the stent out, we will make a one unit, the 2 catheters and instruments as one unit, and maybe our wire and our balloon, our safety balloon, will be also retrieved. The second scenario, that we will take only part of the stent that protruding to the aorta, some of the stent that protruding to the aorta without taking everything out. And actually, when we close the snare and pull the system out, as you can see here, all the stent is out. This is the distal stent, and we could manage with keeping the safety balloon in the distal stent for safety. The patient was hemodynamically stable, no STT changes, no chest pain, so we decided that we don't need this balloon for safety now. And all as one piece was pulled to the abdominal aorta, as you can see here. Then we release all the content of the catheter from the left radial approach and take the stent with the snare into the catheter and taking all the system out. As you can hear, this is the snare out. We didn't complete yet. The stenosis in the left main still there, and it's a calcified stenosis. You can see here IVUS of this stenosis. We make with the balloon, I think, some deformity of the stent, as you can see here, of the stent in the left main, of the distal stent. And you can see here the ostial left main with a calcified stenosis and minimal luminal area of 4.0 millimeter square. We decided to perform IVL, 8 cycles of IVL, 80 heats of IVL was performed here, and then it was dilatable. Before that, the lesion was not dilatable. And we decided to go with the Synergy Megatron stent in provisional approach from the ostial left main to the LAD. Here in a caudal view in order to see the landing zone in the distal landing zone, and in iliocranial view in order to see the proximal landing zone of the stent. And here is a proximal optimization with balloon. This was the angiographic result, and checking this with IVUS showed a under expansion of the new stent. So we expanded it with balloon, then we perform kissing only with balloon to the ostial circumflex. I have an IVUS of the ostial circumflex which is not involved and have no atherosclerosis in the ostium. Repot, and after repot you can see the angiographic result of the left main stenting, and it is from cranial view, and you can see here the result in IVUS. So as you can see here, the distal landing zone of the stent, there is no edge dissection or hematoma. Just go more rapid.
1 minute, please. 1 minute.
Conclude, please. Conclude.
Okay. I have 1 minute, please. And as you can see here, this is the bifurcation. The bifurcation, there is free of struts there, and the ostial circumflex was okay. 2 layers of stent that we couldn't recognize even that there is 2 layers of stents, and we have no geographic mess in the ostial left main, as you can see here, and maybe 1 strut protruding to the aorta. So cranial view is important to avoid stent protrusion to the aorta. It's very basic and simple. Little is known about removal of diploid stents, and I think we described so-called unique technique to do this, trying to increase the rate of success and the rate of safety. Thank you.
Thank you, Haitham. You make an extraordinary job, and for this I should say a few words extraordinary for you. أقول لك فلسطين تعلو وعراقها في الجنين. فلسطين تعلو وعراقها في الجنين والأردن الشماء عشق الملايين. شكرا لك.
الله يخليك. أنا بس بدي أقول لك شكرا جزيلا أول شيء. في كمان لغة إذا وقعت على أسماعنا كانت لنا بردا على الأكباد، ستظل رابطة تؤلف بيننا فهي الرجاء لناطق بالضاد.
I will invite my brother Dr. Rami, also from Palestine, to speak about how to navigate a complex lesions.
Okay, our case is a 67 years old male patient with hypertension, and he presented with recurrent chest pain 2 hours before his admission, and the anterior STEMI by ECG. He's still in chest pain, and hemodynamically he was stable. He was taken to the cath lab and by another physician, and there was occlusion of the mid-LAD. The mid-LAD was occluded. After that, we can see there's some flow in the LAD, and they passed a wire, and by the flow, before that I will return back. So, okay, they put 2 stents in the mid and distal LAD, which was 3.530 and 2.7530, and we can see the stenosis of the left main, distal left main, ostial LAD, and a long lesion in the circumflex itself, the ostial circumflex, and the OM. The treating physician decided to treat the left main to the LAD, and deployed a stent from the left main to the LAD, a provisional stenting, and treat the distal LED, and this was the final result during the same day. It was a prolonged procedure during STEMI, and they decided to stop and not to treat the circumflex at the same time. The patient was stable, and 2 days later, he was brought to the cath lab to treat the ostial circumflex and the obtuse marginal. 2 years was passed to the LED and the circumflex, and after balloon predilatation to the circ, they deployed a stent in the OM and ballooning to the left main circumflex. A trial to pass a stent to the circumflex was very difficult, even after many trials of balloon predilatation. They increased the size of the balloon, the high pressure balloons, but still the stent can't pass to the circumflex. Report of the left main stent increased the size of it, and after many trials, they pass a stent, but it can't pass. They try to pull it back, and the balloon is coming out without the stent. So the stent was dislodged in the left main in the direction of the circumflex inside the old stent. The treating physician tried first to pass a small balloon. He have a wire inside the stent, and to pass a small balloon inside and to take it out, but the small balloon can't pass this angle. So he proceed for twirling technique with passing multiple wires beside the stent. You can pass the wires there, and after that, reaching the area to twist the wire in the outside, you have many wires, one inside the stent, many wires outside the stent, and to twist it in the outside, it will make a loop beside the stent and after the stent, and to pull back all the system together. So he tried to do that, and he passed multiple wires. During the twirling technique, the stent cannot go back, and he lost his wires from inside. So no wire was inside, and they called me at this point to come after many hours in the cath lab. We passed a wire to the LED, and we put a balloon for stent posting, and during this time we can see what's happening inside. We have the stent, old stent in the left main. The stent is going to the LED, and we have the deformed, dislodged stent in the left main to the direction to the circumflex, and the 2 dots of the balloon. We start to think what we can do else, and we decided to go for snaring. We took intracoronary stent and made 4 millimeter, which is a long snaring. We catch the stent at this point and took it back, pulled back the stent. We took back, it was difficult really to catch the stent and to take it all the way down and to take it out. At this point we have the stent in the outside, and we decided to proceed to treat the lesion. After many trials to pass a wire and the balloon to the circumflex, it was somewhat difficult, and we passed a trial to pass another stent. Also, we have the same difficulty to pass a stent to the circumflex. So we took a guide liner, 5 French, to pass the guide extension to the circ itself. It was difficult to take 6 French, the usual guide liner, because we have 2 wires. If we took a guide liner over the 2 wires together, we will not reach the circumflex. It will be difficult. So we go with undersized guide liner 5 French, and we insert it over the wire to the circumflex, and we leave the wire to the LED beside. We did a PTT balloon assisted tracking technique by inflating a balloon in the circ, advancing the small guide liner, 5 French guide liner, to the area of the circumflex. At this point, when you have the guide liner inside, we took the balloon out, and it was easy to advance the stent inside the guide liner to the area of the circumflex, pulling back the guide liner out all the way. So we have 2 wires now inside, 1 wire to the LED, 1 wire to the circumflex, and the stent itself inside the circ, pulling back the stent to the area of the left main. Now we have to finish the procedure, so we decided to go to the tap technique. Just that small protrusion of the stent in the left main. It was 2.7518 millimeter. Inflating the balloon, inflating the stent, deploy the stent in the circumflex and LAD. We have a barking balloon in the left main LAD. We did a kissing balloon inflation and final port with 4.5 millimeter. And this was the final result of the procedure with a good result in the left main LAD and the circumflex. Because it was really a very, very prolonged procedure and all the staff was exhausted after many hours because of the first trials. We did not finish with the intracoronary imaging, but this was the result and it seems a good result. So that in this situation we have to do a maximal stent preparation before bifurcation PCI. Bifurcation usually is more fibrosed, more calcified than any other area. We need to use a stent post clear imaging to understand what is happening inside the situation. We have the bailout options for stent loss, either using the balloon inside the stent if you have the wire inside, twirling technique, snaring of the system, and to think about the small guideliners in this situation. Okay, thank you.
Rami, thank you for this case. It's a pleasure to introduce Dr. Hani Abdelhadi. We worked together in Manchester Royal Infirmary as the two Palestinian fellows in cardiology. Now he's a pronounced cardiologist in Saudi Arabia with special interest in complex intervention and imaging. Please go ahead.
Thank you. Thank you. Munadirin for the very last lecture. So let's finish on a high. It's a pleasure to be here again today. So we're going to talk about high-risk patients with poor AF and certain outcomes. And we're going to go through a few cases just to discuss the topic. So we'll start off quickly with this 72-year-old patient. Why? So this 72-year-old patient who's hypertensive and diabetic, presented with class 4 angina and class 3 heart failure symptoms. Echo showed an ischemic cardiomyopathy with an EF of 25 to 30%, with clear evidence of viability and ischemia in the LAD territory on myocardial perfusion, on cardiac MR. So we discussed him in the heart team MDT, and you'll agree that the LAD is not very nice for grafting. So we thought he's not a very good case for CABG. Very heavily calcified. So there's proximal left main disease is heavily calcific proximal LAD disease, and we quite anticipated that this patient will have hemodynamic compromise if we go ahead with standard PCI. So we do this as an impeller protected PCI. We started off with IVUS to the circumflex, determined that it wasn't bad enough, and we can go ahead with single stent strategy, LAD to left main, and treat it provisionally. So normally this is fairly standard PCI. All of us can rotablate this pretty easily, but the concern here with somebody with an EF of 25% and left main disease, once you start rotablating, you might have slow reflow, you might have issues with hemodynamic compromise. And I'd normally start with a 1.5 burr, but in this case I took a 1.25 because I really don't have slow reflow. We took our time, he was stable, we did a 1.25 burr, a 1.5 burr, cutting balloon, re-imaged and confirmed that we were able to fracture the lesion. We then continued with standard PCI, so stent LAD to left main, pot, kissing balloons, pot again, with an excellent angiographic result and an excellent imaging result. More importantly, if we look at this patient's echo at 6 months and post-procedure, so there's a lag in the system, which is why I keep getting this.
It's very sensitive.
System بعلق معلش هلا نرجع لورا بنرجع لقدام. It's okay. So when we re-echoed this patient in the long term, clearly this patient is now completely asymptomatic. His left ventricular dimensions have reduced, his ejection fraction has improved significantly. I don't know why it's not playing, but I'm going to play them individually. They should play all 4 echoes. يا شباب مش شغال الفيديو هون. الفيديو المفروض يشتغل للأربعة. Yeah? All of them should work. And they all worked before we started this. هذا أهم فيديو من كل التوك. أرجع لورا قدام. Sorry, we've got before and after echocardiograms. You believe me, خلاص. His EF has gone up significantly from 20% to about 50%. And the left ventricular dimensions have improved. خلاص, we'll go to the next slide. Haram. Our next case is a 46-year-old young man, very young man, dyslipidemic, no other risk factors, works in an oil rig offshore. came in with class 4 angina and a minimal troponin rise and class 3 heart failure symptoms. His echo showed an ischemic cardiomyopathy with an EF of 20%. And we did an FDG PET scan that showed widespread viability. So let's look at his anatomy. The LAD is gone. And you can't really see a distal LAD filling from anywhere, right? What you'll also notice is the big dominant right is an occluded vessel and fills via this small epicardial from the last remaining vessel, which is a circumflex. So we discussed this patient at our heart team MDT, and again our surgeons felt that this is really not a good candidate for surgery. If we're going to open the chest of a 46-year-old with no LAD to graft, then really there's no real point to do this just purely for the RCA. So we took a decision that even for PCI, if I can't see an LAD, and even if I go into a very small distal LAD, stent it all the way back to the left main, it's not to this patient's advantage. So the option here is to open the RCA. The concern about doing the RCA, he's got one remaining vessel with very poor LV function. If you end up going retrograde via this small collateral from the last remaining vessel, you could really compromise his hemodynamics. So again, this had to be an impella-protected PCI. You'll see here that we initially went with antegrade wire escalation. I couldn't really solve the distal cap, kept going into a false lumen distally. So we quickly transferred to a retrograde approach via the last epicardial. Very straightforward. We wired true to true from distal, did a ballooned and stented with 2 overlapping drug-eluting stents with an excellent final angiographic result and an excellent IVUS result. Let's hope this video plays for the echo. Come on. No, it has to play. So the echo at 6 months. There's a small changes in the left ventricular dimensions, but the ejection fraction has improved significantly from 20% to 45%. And we followed up this patient up to 18 months post-procedure. Again, NYHA1, CCS class 1, completely asymptomatic with no events. Now I discussed with him re-imaging him. I wanted to do a cath to see if the LAD shows itself. Because my opinion here is if we can see an LAD, maybe we can do a minimally invasive Lima to LAD. I still don't want to stent him. But the patient said, look, I'm completely asymptomatic. I work on an oil rig. I don't want to lose my job. I'm quite happy to proceed with medical therapy. And to be honest, it's fair enough that we keep going that way. Our last case is a 72-year-old lady who's diabetic, hypertensive, CKD, blind, and extremely frail. She initially presented to another hospital with a non-STEMI, decompensated heart failure, a moderate pericardiofusion that they state at their institution, severe LV impairment, had a cath there that showed severe multivessel disease, and got turned down by 2 cardiac surgeons in 2 different centers, and she was referred to us for a third opinion. On arrival to us, she was in tamponade, so we drained her pericardiofusion, and then we repeated her echo. I think you saw the echo earlier. She's got very poor LV function. And if I show you her coronary angiogram, she's got this severe multivessel coronary disease. We're not sure how bad the left main is angiographically, but there's clearly severe proximal LAD disease, heavily calcific mid-LAD disease, and a CTO of the dominant right coronary artery, which feeds via collaterals from the LAD. So we've got severe multivessel disease. If we look at the IVUS of the left coronary system, the proximal left main is diseased, not very tight, but there's an MLA of 8.4, it's quite eccentric, but the mid-left main is quite tight with an MLA of 3.5. So we've got severe mid-left main disease, we've got this heavily calcific mid-LAD disease. So you know you're going to have to do this procedure with a lot of support, because the moment you touch one of her vessels, she has no flow. Yeah. So again, impella-protected PCI, IVL to the LAD with a 3mm shockwave followed by a 3mm NC balloon, confirmed fracture with IVUS. We then treated the OM branch with a 1.5mm drug-eluting balloon, and then we treated the LAD to left main with 2 drug-eluting stents, which we then optimized and checked with IVUS with a good result. Keeping in mind she's got CKD, so we try to do this with minimal contrast. We don't do any tests, we do injections throughout. So we initially tried to go antegradely and again couldn't solve the distal cap, so we took a retrograde approach. We did a reverse cart with 2 drug-eluting stents and ended up stenting with the RCA with 2 drug-eluting stents with an excellent angiographic and an excellent IVUS result. So this patient's creatinine is, we used about 80 mils of contrast for all 3 vessels. She was fine. Her creatinine went back to baseline at 48 hours. She follows up at a local hospital which is 150 kilometers away, and the feedback we got from her local cardiologist is that she had no further events. Her echo showed an EF of 40% post follow-up. So here we presented patients with severe LV impairment who've had significant improvement in LV function, NYHA and angina class after impella-protected PCI. This is fairly similar to results mentioned in Restore EF, which is a fairly small study and is observational, but there did show evidence of LV improvement, especially in patients whose EF at baseline was below 35%. Hemodynamic support enables you to perform state-of-the-art PCI. You know, if you've got an unstable patient, then you don't take your time, you don't do things properly. If you have a stable patient, you can take your time, you can perform contemporary PCI, you can use intravascular imaging, you can fully prepare your lesion, and you can fully optimize your stent. If I draw your attention to this doesn't work, good. If I draw your attention to the graph, the top left one, over here, you'll find that this patient's mean arterial pressure throughout the procedure was about 75. And you can find here that we achieved flow on the top right corner of nearly 3.7 to 4 liters per minute throughout the case. So you've got a stable patient, and you know that you can do a better job when your patient is hemodynamically stable. If you start to do your case and your patient's blood pressure drops, and if they're ischemic, then you take shortcuts and you don't do a proper job as you normally would. So once you're able to do that, then you're much more likely to you'll increase your likelihood of achieving complete revascularization. And we know from the syntax data that if you have complete revasc with a lower residual syntax score, then you'll have much better outcomes, both for major adverse events and for mortality. Thank you.
I think we open the floor for discussion, and I don't know how much you can tolerate more time with us. Let's we start with any question from the audience. Everybody get exhausted.
يعطيكم العافية. Thank you very much, all of you. If I go maybe to the the last one, Dr. Impella. I think in Jordan you don't have Impella, so I just want to see the Jordanian how they've approached this case. Your cases, and maybe you can answer. The first and the second one. The first was about, that was something new for me, to remove the stent. You know, we normally say, the patient come to us, Doctor, can you remove the stent after some years?
Yeah.
You know, but nice to see that's happening. So I would have, you know, it's not a criticize, but this is for the future, I'm saying. If we can either, you know, put a stent with meticulous way, especially in left main, or you know, don't avoid putting a stent in left main and use DCB, which is a new study now available for that compared to the stent. And the second case was about somebody who came with a STEMI and had a left main LCX. I normally deal with the culprit lesion, and I give time for the re-evaluate the other lesion. Again, it's nice to speak responsibly, but again, it's important again to focus on the lesion which brought patient to the hospital. Thank you.
So, in a brief, from Dr.
Sorry, last question. Last question to my friend here. Last question to my friend here, because speaking about problem with the DCB is severe recoil and bad dissection, or no reflow. Sorry, no reflow and bad recoil. Bad recoil. I think if you a bit patient, you know, recoil is not a big problem, but no reflow. There's no answer to it. You put a stent, you get no reflow. So wait more, and you get the answer. And last question about the calcification. If you have calcified, I think now we have an answer. You know, you can, whatever you put a stent, you have you have stent regret in the future. You know, whatever you do with that lesion, calcified whatever you want, remodeling, I mean, all the bulking we have, the stent will not have a proper answer for you. You want to heal that naturally, I think, and DCB should be an answer for that. Thank you.
I think Dr. Klaus can answer this question for the, please, the DEB in ostial circ, for example, in this case, and using the DCB in left main, and also in, I'll tell you what he's doing. He's doing DCB in acute coronary syndrome and ST elevation MI. So I'm just to tell you what he did.
I know very well the beautiful cases with the use of the DCB and ACS. First, DCB in osteum of the circumflex, we use routinely the DCB in any scenario, whether it's LAD, diagonal branch, CX obtuse margin branch, or distal circumflex, distal left main circumflex. In complex, in 1-on-1 situations, in many cases we prefer stenting of distal left main LAD and to do the DCB for the ostium of the circumflex prior to the use of the stenting. There's one scenario we left. It was the use of the DCB only for ostium of left main. For this special scenario, but also for ostium of the of the right coronary artery, we met bad experience, to be honest, because there was more recoil, more calcification, and we made. I guess we have poor results for the stent. We have poor results for the DCB as well. But the world changes completely as soon as we are a little distal of the ostium of the left main. From this scenario, we use it in the same way, and we know from preclinical data that calcium has not a negative impact. It has a negative impact on the result maybe of our lesion preparation, or it becomes more challenging. But now at times we have amazing tools to improve this plaque modification, and we have a lot of signs that with the improvement of the lesion preparation, we have definitely better results also for the DCB. But to be honest, for any following procedure, not also for the DS, any investment on lesion preparation improves our result.
For the preparation, is it a must to use the scoring balloon?
In my opinion, it's a brilliant tool. In our CAS lab, we were performing around about 1,100 PCIs per year. We're using around about 600 DCB, and I'm using 450 scoring balloons. So it's almost a standard tool for calcified lesions, for osteal lesions. We made good experience with this scoring plus DCB, as I presented, with TLR of 0.8. But any tool we have is appropriate. And by the way, in long calcified lesions, such as the case of the LAD, we use a small burr rod ablation, not more than 1.5, but final size scoring plus DCB, and if really needed, spot stenting DS.
And the intravascular imaging.
The intravascular imaging is helpful, in my opinion, in instant restenosis, is helpful, in my opinion, for left main, but it's, according to all experience and also to the data, it's not an essential step for the decision making in the use of the DCB.
I briefed the questions that were asked before you come, so this is all. Thank you. Any questions from my colleagues? Raed, here, please. Dr. Abdullah, please.
Regarding the stent which was hanging in the aorta, we face many times some operators when they do the ostial RCA or ostial left main, by mistake or fault, they would hang up like 4, 5, 6 millimeter outside. This is common, and the patients will come back with restenosis. And the problem here, how to intubate the struts which are hanging in the aorta, because it's very difficult. So from my past experience, I have like 2 cases in the ostial RCA, but in this case, I don't think this technique will apply, because this is a complete mistake. It's like 15 millimeters.
All the stent is out.
There's no way except to snare it. But there is a technique called side strut stenting technique. It is mentioned and reported, where you cross from whatever side, lateral side or above the stent, and then you cross to the main artery. You try to dilate one of the struts, and then you advance another stent. You place it ostially and inflate it at high pressure, excluding the rest of the struts. Mm-hmm. Now one would ask, what about these stents and what about the anticoagulation regimen after that? It's like the frame of a tab. There would be some struts hanging around and flower, around the ostium. It will be okay. I had a follow-up for one patient in the right, that was in the right, and the stent was patent.
Okay.
This technique is called the side strut stent technique.
Yes. Raed.
Thank you for the nice lectures and the nice cases. I think for us as cardiologists in the era of drug-eluting balloons, I think we always resist changes. And I think we should start to shift our attention to not always say it is stent-like results. We use that lots. Or the artery looks like it was new. I think we should start insisting on patency of the artery, adequacy of flow, regardless of the residual stenosis. I think that will make us move to the next era of drug-coated balloons, because I think they are promising, and the less metal in those arteries, the better we are for the future. Thank you.
Dr. Samir or Samir.
Thank you, Rami, Hani v. Haitham. It's excellent presentation. Rami, about your case, you did not from the beginning start this case, but this lesion in the circumflex is 90 degree. So if you are from the start, you have intention to stent the circumflex and the LED, I think it's better to do DK crush and to stent the circumflex first of all, because it's very sharp angle and it's difficult sometimes really to pass these stents.
Thank you, Samir. Actually, it was not my case at first, and you know, in STEMI cases, I think that you have to deal with the pelvic lesion. This was a prolonged procedure, and they treat the mid-LED lesion, which was really totally occluded. The question was if they had to stop and not to stent the left main at the same session, but they decided to treat the left main in the direction of the LED. Whenever you have this, sometimes I think this is a case for two-stent technique to start with. You have a long lesion in the circumflex, and it's involving the ostiums more than 10 millimeters. Of course, it's a case for two-stent technique to start with. But if you treat the case as a provisional and they just want to finish the case, it was good result. And 2 days later, there was a use of blood contrast and a lot of injections, and decided to go back for this lesion. Whenever you have to finish the case, now you have a stent in the left main LED. The options for the treatment to go with a kilot, but you will know this is an angle, and the huge angle. It's not a good case for the kilot, and also there is a difference in the sizes in the two stents. The second option is the TAP technique to finish with it. I think that this is the best option whenever you have it to continue like a provisional and to finish with a TAP technique. So we finished with a good result at the end, but I believe that it's a good case for two-stent technique to start with.
I think to start with the stenting the circ will be easier. But let me ask a question, Mustafa, before. How frequent do you have coronary snare in the cath lab? Who has coronary snare inside the cath lab? Coronary snare in Palestine, it seems to be. Coronary snare inside the cath lab? I don't know any cath lab have it in Jordan, I think. And if you didn't have the coronary snare, what another solution you think, Rami?
Actually, they tried the two solutions to start with. They had a wire inside, and it was the easiest way to go with the small balloon or 1.5 balloon to proceed through the stent, the strut of an open stent, to inflate it distally and to take all the system together. But
you lost the wire.
Sorry?
You lost the wire.
Yeah, we lost the wire.
Okay.
So twirling technique still it can work if you are going through one of the struts, but and to do the twirling, they tried the twirling technique. If there is the other options, if you don't have the snare, to proceed with a guide extension inside to try to inflate to go wire guide extension with a guideline 5-6 French to do intubation and to play the balloon distally and to take all the system together. It may work in this situation.
It's difficult.
Rami, you can make a snare also. You can make a snare.
Snare?
Make a snare, yeah, of course. If it is a question, you can make a...
Actually, we didn't have crawler snare.
Try to snare the circuit stents through the left main stents, which is deployed previously. You will deform the hole because these stents were inside and partially deployed. I saw that if you try to snare them by whatever means, the circuit stents. I think the best way here to recross to the circ and just deploy them across the wall to just...
I totally disagree. I think when you can take the stent, you can see the stent is more than 90% of the stent in the left main itself, undeployed stent. If you are doing a crush technique for in this situation, so it's just a time to have a thrombosis there and occlusion of the circ, which will be protruded thrombus to the left main, and the patient will not survive.
Migrated to the left main.
The stent, they had two stents in the circumflex. One stent was deployed in the marginal. The second stent during the trial to pass the stent, it can't do the angle. So it just entered the circumflex by 4 millimeters, and during trial to take the balloon and the stent back, they lost the balloon. So it's undeployed in the left main, the direction of the circumflex. Yeah.
Try to extract it if you could not. I think a crushing gate is not a bad idea. Dr. Mustafa.
I was convinced by the DCB when you first explained the basic principle, and I suggest that every time you talk about it to repeat this principle. The principle as the following. In the era before stenting, people used angioplasty, regular angioplasty. And the complication of this was acute thrombosis and late restenosis. But that was in the era where there was no ADB inhibitors. Once ADB inhibitors appeared, and according to all trials on DCBs, the rate of acute thrombosis is 0. Is this right? 0.
Can you give the mic to Dr. Klaus, please?
And
you can use the stage, please.
And to avoid late restenosis, then they used the DCB. And the results compared with this was non-inferior.
Yeah.
Less than 6% target vessel revascularization. And when you get dissection type A, B, but no C, you don't need even to stent. You don't need even to stent that vessel. You stent that vessel only if you have a class C dissection or limitation of flow.
How you reply to this, Klaus?
Agree, and I mean, we're all sitting here to learn from each other. And what I had to learn during the last 10 years is a huge change in my way how to address a lesion and how to handle dissections and all the picture I got after lesion preparation. Honestly speaking, I started interventional cardiology in 1993 in a year without the stent, right after the use of the bare metal stents. So I grew up completely with this huge amount of stenting. And then when I left for the first time a lesion without the stent, I did not feel very comfortable. And I've always had the feeling there's something missing. And what is mostly missing for me was the safety, because I knew these beautiful pictures for one or two decades in my cath lab, and I used to see these beautiful immediate results. And then it took me several times, maybe 2-3 years, to build up confidence in this result that looked not that beautiful at the index procedure. And then we learned type B dissection, type C dissection are completely stable in the era of routine use of the APT. All these classification with A, B is good and C plus is not good is running from, you have to take this into account, from 1985. from an era without the APT, no clopidogrel, no ticagrelor, no prasugrel, no stents. So at that time, the only way to handle a huge dissection was to call the surgeons. So now we are using preloading all our patients on aspirin plus clopidogrel or even ticagrelor, prasugrel. We can leave a non-flow limiting dissection without any problem. And you saw, I showed you the case of this osteal LAD. I feel completely safe with the DCB, more safe than by using a DES at the ostium of the LAD. Because I know the rate of thrombotic events for this lady will be almost zero. As soon as I use a DES, I use hundreds of DES as well. But when I don't need it, I don't use it. And when I use the stent, and from that moment, there is a lifelong, a low but a lifelong risk for a thrombotic event. And this I will not have with the DCB. So I totally agree, but it's a challenging point in our decision making to leave a type C dissection without a stent.
A question of the drug, paclitaxel or sirolimus, the amount of drug will deliver from the starting point from the sheath till you reach to the lesion. Is it important?
It is important, definitely. So the recommended time is 2 minutes to advance the DCB within 2 minutes.
For both of them, paclitaxel, sirolimus, I mean, how much it will lose from this one or this one?
Yeah, I think 2 minutes is too much. We don't hurry, but we work straightforward. It is my recommendation is to connect the inflation device outside to optimize the backup and then to inflate within 30 seconds the DCB, because from the moment we enter the Y connector, we lose drug.
How much? Do you know how much?
No, we don't. I don't know how much exactly, but when we inflate within 6, there is I know a little, because about 70% of the drug with the C-Complex Neo, about 70% or 17 of the drug load is available in the vessel wall when we inflate within 60 seconds.
Great.
And I know from other DCB where the drug load is much less because they lose much more drug on their way to the lesion site. But honestly speaking, I do not know the difference compared to the sirolimus-coated DCB.
So, Raed, do you have a question?
So Klaus, not being sarcastic here, I don't know if this is true in Europe. In the US, when the general cardiologist does the angio and he calls you for the intervention, he will introduce you to the patient and saying, this is the stent doctor. So maybe now we should switch to the DCB doctor.
I don't it's a good idea, but I think we should switch to the hybrid doctor, to the flexible doctor, to the open approach to use all contemporary tools. And I'm pretty sure I will use newest generation DS until the end of my career, because there are cases when we're happy to have them. But on the other side, there are a lot of cases when patients have better long-term results when we use the DCB. And my switch, what I pray in our CAS lab day by day is, it's not our job to do coronary cosmetics. It's our job to produce best possible clinical long-term results for our patients. And by doing this, sometimes we have to deal with complex pictures and complex situations.
Diffusely diseased vessel, Klaus, diffusely diseased from the ostium or proximal down to the distal, very distal. Any experience with the DCB? Did we change our approach because it's just medical treatment?
You know, whether it's diffusely or focus, the result is, in my opinion, is the same. It's more challenging for the lesion preparation, but as soon as the lesion preparation is adequate, I use the DCB, whether it's focal or not, or diffusely or not.
Have you some cases like this?
Sure.
Okay,
Yeah.
that's good.
One question. If we assume that scaffolding the proximal parts of the coronaries is not that important, putting something with the drug, how do you explain the recent resurgence in scaffold technology, the recent interest? People are saying that there are new scaffolds now.
For new generation BBS, you mean?
Yeah. And how they will compete with the DCB, because you have more protected, you're more protected. You have a scaffold and you have a drug, but DCB you don't have a scaffold. So you're leaving the area which you balloon almost, naked.
I mean, we have to combine the benefits of the two three worlds. The scaffold always means, as long as it does not disappear, the scaffold always means a limitation of the diameter. There will be no positive remodeling, no lumen enlargement in a world with a DS. From the moment of the implantation, it can only get worse. In best case, it stays stable. Maybe one day we will have a cath lab where we work completely implant-free. We do DCB plus bailout stenting BVS, maybe with the new generation.
Yeah, but all the studies with the scaffolds, they showed after 6 months, after the scaffold get absorbed, that there was positive remodeling, and the vasomotion will come back.
I'm sorry, but no, they didn't. With the absorb, not. It was worse than the science, and the vasomotion they left, or what they promised is that they keep the vasomotion or they get the vasomotion back, but they didn't. The presentation at the TCT was absorb, loses.
Hope that with the new scaffolds,
exactly,
because the concepts are the same.
Exactly.
It's like you are.
Really, this is exciting. Thank you very much. I think we should finish this session and finishing our conference for long 2 days. I'm so happy actually to see all of these numbers. All of you are still sitting here waiting and waiting with us till the end of the day. Thank you very much, Dr. Mahmoud.
الله يعطيكم العافية. تعبتوا اليوم ها؟ الدكتور زياد موجود؟ دكتور زياد، احنا سعداء بوجودك يا دكتور زياد. في دكتور زياد والدكتور رائد. دكتور زياد closing remarks والدكتور رائد يتبعها.
رائد عقل.
Good afternoon, everyone. First, let's give big hands to this individual here, Dr. Mahmoud, and the organizing committee. Congratulations on the success of this wonderful meeting. The last 2 days we witnessed excellent speakers, excellent topics that touched on all aspects of interventional cardiology, and I was lucky that I was involved in a small part, the congenital, so it was very good. And I also listened to some of the talks that you guys here gave, so really congratulations. Putting a meeting is not easy. And I talk from experience. I run an interventional course that I started in 1997, the PICS course, maybe some of you heard of it. And we are into our 27th year doing the course in Washington, D.C. this year, in the end of August. So it takes a lot to put a conference. So again, congratulations to the organizing committee. I want to thank all the speakers for their excellent talks. And most of you stuck to the time, which is very important when you run a meeting. I want to thank the industry partners, because without their support, such meetings could not take place. So partnering with the industry is extremely important, so I want to thank all of them for their support. I want, of course, to thank the attendees, because you are the people who make the meeting, and you stuck to the end of the meeting. Of course, the AV teams, they did a great job using really great technology. The pointer, this is the first time I see such pointers. So congratulations, guys, for this. The ladies here who held the microphone and this, let's give them all big hands. So again, thank you for having all of us, Mahmoud and the organizing committee in Jordan, and I hope that our guest speakers who flew from abroad will have some time to enjoy what the kingdom has to offer. Thank you and good evening.
السلام عليكم. وطبعا بعد دكتور زياد we cannot add much. لكن بالنيابة عن الأورجنايزر كوميتي وباسم جمعية أطباء القلب الأردنية نشكركم جميعا. حللتم أهلا ونزلتم سهلا. هذا بلدكم الثاني إن لم يكن بلدكم الأول. مبسوطين تعرفنا على وجوه جديدة، تعلمنا منكم الكثير، وإن شاء الله في لقاءات أخرى برضو احنا بنتطور معاكم حسب الاشياء اللي شفناها، فشكرا جزيلا لكم جميعا. وان شاء الله بقيه السهره هنا في عشاء، الدكتور محمود بجوز حكى لكم في عشاء هنا، فالعشاء على 7:30. تفضل محمود. فشكرا لكم.
احنا بس بدنا ناخذ صور جماعيه مع بعض. يلا تفضل.
أول شيء